So one of the things I think that we really wanted to talk about today are some of the issues around remote patient monitoring that are really problematic. And a lot of the issues have to do with reimbursement and billing and not being able to bill things, billing for things in strange ways. And one of the things that really, I had a conversation with Drew, Drew, it's probably like couple of months ago now, where Drew started to educate me on some of the problems that they're having right now and that some of the challenges that remote patient monitoring companies have around reimbursement. And can you just kind of go into a little bit around some of the challenges that organizations such as yours have, Drew?
Yeah, totally. Yeah. Thanks, Jen. And, hopefully we can get Jaren back in. Jaren is on the DIMPAG, which is the Digital Medicine Payment Advisory Group, which is the group that that within AMA that actually puts forth these codes. So Jaren can certainly go into a lot of these in more detail, but I have been certainly apprenticing under Jaren in many ways. So, I'll say first as an overview, I know that a lot of questions came in around what are the remote monitoring codes specific for 2022 in the Physician Fee Schedule. And there's some additional new codes being proposed for remote therapeutic monitoring, which is slightly different. And so I'll kind of walk through those at a very high level, but RPM
maybe
code,
you could even just to kind of set the ground level here, when we're talking about remote patient monitoring, what kinds of devices are we talking about?
Oh, yeah, totally. Absolutely. Happy to do that. So really what we're talking about is any FDA listed medical device that a patient has that captures physiological data from somebody, and those data are brought from the device to the healthcare system for the purpose of patient care. And so in this instance, it's actually a really interesting distinction, which is when we talk about RPM in the industry, we're mostly talking about remote patient monitoring, but CMS is actually specifically designating this as remote physiologic monitoring. And so physiologic is anything that actually is a true biometric reading. So a glucose meter, for example, is taking your blood glucose. That is a physiologic measurement. A blood pressure monitor is taking your blood pressure readings. That is a physiologic measurement. A spirometer is taking the reading of lung function. That is a physiologic measurement. However, an asthma inhaler that has connectivity to recognize that a dosage was dispensed and physically where that dosage, like GPS-wise, where that dosage was dispensed, that's not actually taking a physiologic reading. So that's a therapeutic measurement, but it's not a physiologic measurement. So
what about like Fitbits, scales, those kinds of things?
Scales, as long as they're FDA listed, are good. Fitbits are not included because they're not classified as a medical device by the FDA. So it is medical devices as classified by the FDA that are brought in for the purposes of managing a patient population, specifically, generally speaking, around acute or chronic diseases. So the types of programs that we're talking about and disease states are things like diabetes, hypertension, heart failure, which is typically more acute, but certainly falls into that purview. COVID-19, actually interesting, is it does fall into this. There was a very specific exception made to these billing codes during COVID, where typically speaking, you have to, in order to bill for these codes for the actual utilization of monitoring devices, you have to track someone for a minimum of 16 days in a calendar month. But because the monitoring for COVID was 2 weeks or less to make sure that somebody is doing okay, that time actually during the public health emergency was shortened to 2 days specifically for COVID monitoring. So you had to someone had to be tracking with a thermometer and a pulse oximeter for at least 2 days to be billed. But I'm kind of getting in the weeds, but the long and short of it is what we're really talking about is data that people are capturing in their homes, in their daily lives. The data are brought into the healthcare system where physicians, nurse care managers, et cetera, are able to receive those data and review those data and provide proactive care based around that. And so they can actually know ahead of time what's happening.
Do they have to be FDA approved?
The devices have to be. Yes, the devices have to be FDA approved in order to in order to be billed for these services.
Because we did get one comment from someone who said that that can actually be a little bit limiting.
You know, it really depends on the type of disease state you're talking about, right? For diabetes, the glucose meters are certainly covered. For you know, hypertension, the blood pressure monitors are certainly covered. For a lot of the big ones, for COPD, you know, you have pulse oximetry, et cetera, that are often that are you know, cleared by the FDA. So I think it's really, if you're looking at more wellness initiatives, or other sort of initiatives that's just not, you know, covered under the remote physiologic monitoring. And, you know, it looks like Jaren's back in now, and I don't know if Jaren has any specific questions around, or specific comments around why it's FDA specific devices. But that is a certain limitation to the codes.
Hello, everybody. Apologies for the massive technical disruption that I just suffered. It goes to show that connectivity is a very important thing. I'm actually in Ohio in an area of low connectivity, and you know, ended up missing the first 10 minutes. So my apologies about that. But getting to the topic at hand, Drew, let me be abundantly clear. There was no way that the CPT editorial panel would have ever approved any of the remote physiologic monitoring codes, and to that effect, even the new remote therapeutic monitoring codes, if the devices in question were not medical devices as defined by the FDA. So they don't necessarily have to be approved, because approved is a class 3 device, you know, but they have to be either approved, cleared, or listed as a class 1 device. And, you know, the verbiage that was used, a device as defined by the FDA, was purposely broad because they wanted to make sure that they captured even devices that may have been placed formally under enforcement discretion. And this is a very important thing because, you know, there are lots of guidance documents that have been issued by the FDA specific to general functions that are under enforcement discretion. That means that the agency is choosing not to obligate regulatory requirements, you know, for devices that happen to fall under these functions, or rather, you know, these functions don't obligate, you know, regulatory requirements. But, you know, there are a number of digital health devices that the product code of such devices have actually been placed formally under enforcement discretion by FDA. So those would also apply in this case as satisfying the requirements of the code. And I realize that there are lots of, you know, health and wellness apps that are seeking to do the right thing, but there's no real way for the medical community in particular to be able to differentiate those types of apps from those that are actually have been validated through a quality system, through good manufacturing practices, you know, or other standards, you know, that really, you know, lift their clinical validity. And that's really what CPT was looking for when they created these codes.
So just to clarify, Jaren, so FDA approval is not required, but it has to be a medical device as defined by the FDA to be reimbursed.
That's correct. Yes, okay. That is correct.
All right.
Approval is a very high bar. Yeah, approval is a very high bar, right? That's
okay.
A category, a class 3 device rather, that would require, you know, trials and testing, and, you know, it gets assigned to a panel within the FDA. Typically takes years to, you know, receive or obtain the approval. That's okay. Not what this is, but, you know, in FDA parlance, approval is class 3, clearance is typically class 2, and then listing is, you know, class 1 devices. But there are some that fall under, you know, enforcement discretion that have been called out. Examples of that, you know, a medical device data system that's hardware, not software. Software has been called out explicitly as not a medical device at all, but hardware continues to be considered a medical device, and it's under enforcement discretion, product code OUG. You know, medication.
Quick questions, Jaren, too. Does it have to be API enabled?
It's not so much that it's API enabled, but the device has to be able to automatically upload its data in order for you know, the provider to be able to access it. So that notion of being able to automatically upload its data, yes, I would argue that the only way that happens is through an API. But it's not specific to an API. It's more general in that they're seeking that the data is automatically uploads.
Okay.
Yeah, and yeah, just to add a little color there. So, for our system and our clients receiving these data, we're capturing data where sometimes that we're getting the data from the device manufacturer's cloud and delivering that to the EHR. Sometimes it's direct from a Bluetooth device where there's a Bluetooth API or SDK direct from the device to a mobile phone, and we're delivering it from there to the healthcare system. Or even we have a technology that uses the camera on the phone to read the display of a device when the reading is taken and turn that into a digital asset right there, and then automatically deliver that. So I think the key is, though, that it's not manually entered information by an individual patient, which is really where the line is drawn. Is that right, Jaron?
Yeah, yes. To paraphrase, I'll say it this way: patient self-reported data is not something that CPT was looking for. The problem with that is that there are lots of people within the Medicare program that suffer from either a physical or a cognitive disability, and giving them the burden of having to upload the information by manually transcribing it defeats the purpose of using remote monitoring equipment, which automatically captures that information, that physiologic data, and then submits it to the provider without having to have the intermediary, which would be the beneficiary. They're really trying to, automate this and cut the beneficiary out, other than having them adhere to the treatment plan and, do interact with the device, which is, part of the requirements of payment for the supply. So yes, they were not interested in getting patient self-reported data. They wanted this to be automated.
So if something like a Fitbit or an Apple Watch, unless it's connected to something, and I would assume, just kind of gathering your own self-reported data and then giving that to a clinician, that obviously is not remote patient monitoring. That's just a patient with self-reported data. Is that correct? So
I would qualify that. I wouldn't necessarily agree with that. The way that I would look at that is the Fitbit or is the Apple Watch a device as defined by the FDA, or do they have software as a medical device loaded onto that, what could be a general purpose platform, right? The Apple Watch, and I'm by no means, work for Apple or am familiar with an Apple Watch. I don't own one. But I am aware that Apple did successfully receive two de novo clearances for software as a medical device that were loaded initially on the Apple i4 watch. That's a medical device. Those software are medical devices. Now they're working on a general purpose platform, which is the Apple Watch, but that's no different than software as a medical device operating off of a tablet or off of a smartphone or something else. So that the fact that the watch, does fulfill a medical transaction in a sense, because, but for that software, the watch would not be able to be used to, number one, detect, atrial fibrillation or some other kind of, arrhythmia imbalance. And then secondarily, then be able to allow the patient to, create a waveform, that's represented or displayed on the watch. That I would argue that type of a device, even though it's a general purpose platform, it's actually housing, two medical devices that should satisfy. But this gets into a deeper issue as to whether or not that type of solution is what CMS was intending to reimburse via supply, because when it comes to supply, CMS looks at supply in a very traditional way, which is hardware, and hardware that may have software, but typically it's hardware as a medical device, which would fall under a practice expense of being a direct practice expense. It could be, equipment, and that's the type of thing that they will pay for. But when it comes to software, CMS currently is really grappling with this because typically software falls under indirect practice expenses, and indirect practice expenses are not paid. So this is something that CMS has actually vocalized both in last year's fee schedule and more pressing in this fee schedule.
Sharon, I'm going to ask you to go through that one more time real slowly, and I appreciate your patience with us. So
no, absolutely. So let me clarify it this way. When people love to talk about codes, right? CPT codes, And, the code is actually the 5-digit number, but the descriptor, is equally as important because that's what really describes the service. Once a code is created, and even though I'm an advisor to the American Medical Association, their Digital Medicine Payment Advisory Group, I'm not here representing AMA. So, don't hate me. And if you're AMA, please don't get mad at me for trying to describe this. But, a lot of folks get confused by this. So, once AMA's CPT editorial panel creates a code, that code, along with all the other codes that get created in that, in that meeting, gets sent to something called the RUC. The RUC is a value unit committee that oversees valuation of codes. And they're the ones that come up with a recommended value for a particular code. Now, codes are composed of 3 different values. One is what they call a PE, that's a practice expense. And I'm going to get into that one a little deeper in a second. The other is work. That's literally the work assigned, or the work involved by a provider, whether it be a physician or a qualified healthcare professional, or even a non-physician provider that can bill codes. It's their work. That's what that work value unit is composed of. And then lastly, malpractice. Malpractice is assigned a value unit as well. Those 3 components are how you value a CPT code. So the first one that I mentioned was the practice expense. Practice expenses are pretty complicated. They're derived of 2 different types of expenses. One is a direct expense, which is typically equipment, supplies, and clinical staff time. And then on the other side, you have an indirect expense, which is typically things like software or administrative staff. So, that on the indirect side, that's not the type of stuff that CMS pays for. It's the direct side of the practice expense, which they pay for. And that's what CMS is currently grappling with. And they've done it in a very public, wonderful way because they're asking for, input by all of us. They had, most recently, about a month ago, they had a town hall meeting where Rand Corporation, I believe, is the one that's been given the contract to deal with how they can update their practice expense methodology, which includes a variety of other things that I'm not even talking about here. But this issue of, indirect versus direct and software in particular, falls under their PE methodology.
Let me ask you to walk us through an example here, Jaron. So a doctor's office hands out the blood pressure monitor for the patient to take home to track their blood pressure. Which piece is the direct piece that's paid for, and what is the indirect piece?
Yeah, so under I've got a bad echo there, sorry. So under under the 99454 code, for example, and 99453, those are the 2 as I like to call them, technical component codes, okay, because they don't have a work RVU. They're only, practice expense. And, for both of those codes, when the RUC created those codes, they asked for medical specialty society input by way of invoices, economic data, any other kind of data that can help them come up with what the valuations were or would be, the recommended valuations would be for those codes. And after having received, whatever information and insight they received, that's when they came out and, and assigned those codes a practice expense, as part of the valuation, which then went to CMS, and then CMS decided on what they were going to pay for or not. And that's a great example of, the differences between the RUC and even CMS. When the RUC made its recommendation, and I'm going back to 2019 when these codes were first unveiled, I remember that in the preamble of that section, discussing these codes and the proposed rule, the valuation of the 99454 code was actually twice as much as it is being paid for. And the reason why is because in the descriptor of the code, it says, supply with daily recordings, programmed alerts, transmission. Well, CMS pushed back and said, we're not paying for transmission. That's something that's considered an indirect practice expense. We don't pay for that kind of stuff, even though, the reality is that with these types of monitoring solutions, the transmission is not associated to keeping the lights on in the facility where the doctor is based. right? It's done on it's done in the world, right? It's the device has to communicate some way or another, and they were looking to try to qualify that and provide a reimbursement for it. But CMS didn't see it that way, so CMS said we're not going to pay for that. So as a result of that, we're going to cut the proposed valuation basically in half, and that's what ended up becoming the cost of that code, or the price of that code, which to this day we still have. The 2021 amount was $63.16. It's going to go down as a result of the proposed.
Okay, so that's really an important piece. So basically, they're only paying for the device to capture the physiological metric, so to capture the blood pressure number, but not to transmit it.
But that is a key requirement. Yeah. So
Yes.
Okay. let me walk through how our clients
on
are
this.
using
Yeah.
this. Yeah. So 99453 is a one-time setup code. So that is about $20, and that is literally, for the physician or a nurse or somebody to actually walk through the setup and with that individual and make sure that they have the device connected to whatever program they're going to use and that it's transmitting the data. So that's a one-time fee.
So setting up the blood pressure monitor for the patient, basically.
Exactly. And then 99454 is a monthly expense, where as long as the patient has taken at least 16 readings in a month, and transmitted those readings automatically from the blood pressure monitor that goes to the healthcare provider, then the healthcare provider can then bill CMS, and this is what Jaron was just talking about $60 per month, and that pays for the devices to be in the hands of the patients, and then in practice, it also pays for the service in the system to deliver the readings. Even though that's not.
Do the readings have to be, because we're getting several of these questions, so do the readings have to be, can it be the patient just reporting the readings to the doctor saying these are the 16 readings I got this month, or it has to be transmitted?
It has to be transmitted.
Okay, so to all of you asking that question here, no, the patient cannot just write these down and give them to the doctor's office. It has to be digitally transferred.
That's right, and it has to be digitally transferred. I believe, and Jaron, correct me if I'm wrong, but it has to be digitally transferred in a way where the readings are actually going from the system to somewhere where they can log in, right? It can't be just like a PDF export from something that's emailed, right? It needs to be an actual system to system transfer in some way.
I don't know if they get into those specifics. I mean, I remember somewhere in one of the rules, there was something about a PDF. Somebody asked a question about that, and that I believe that doesn't satisfy. I'd have to go back and look at that. But, in spirit, what they're looking for is that the data, the actual medical device data, reach the provider automatically. That's really what they're looking for. So I would answer it that way. On the PDF question, I'd have to go back and look at that.
If it reaches the EMR digitally, that's what they're looking for.
Yeah.
Okay.
Exactly. Yeah, that's what they want. But
yeah.
They don't want the patient to be the one that has to transcribe. This is all about the transcription of the data. Either the patient, the family caregiver, somebody else. That's not what they're interested in. They don't want that. They want it to be an automated, transaction. That way, it goes directly from the device back into the provider.
Okay.
Right. And then 99457 is the direct practice expense of reviewing the data. And that is it's 20 minutes of review in a calendar month. There's an additional code of 99458 for an additional 20 minutes of review in a calendar month. And that is billed approximately $50, if I'm not mistaken, for each of those codes, Jaron. And then there's also 99091, which is just a physician reviewing the data for 30 minutes in a month. And that's billed at a higher rate, I think around 65 or 70, if I'm not mistaken.
Yeah, if you're asking about the reimbursement for 2021, the reimbursement on 99457, which is the initial 20 minutes, is $50.94, non-facility, $31.75 for facility. And 99458, which is each additional 20 minutes, is $41.17 non-facility, $31.75 facility.
Is there an amount of time or something that the physician needs to look at the readings? Is there any kind of requirement in terms of what they need to do with the readings, or it's just a
No, that is a very, very good question, and one that requires a bit of deliberation. So I'll say it as follows. For any code within CPT, there's something called pre-service work, intra-service work, and post-service work. So for purposes of answering your question, I'm going to, focus on the intra-service work. That's the work required during those 20 minutes, because there is pre-service work that's anticipated as well as post-service work. And typically that's done by other personnel. I'll leave it at that. But the intra-service, description of procedure for 99457 is that the physician or the other qualified healthcare professional would be doing some aspect of medical decision-making in order to assess the patient's clinical stability, and then be able to even communicate the results to the patient and oversee the management and or coordination of services as needed. The part, that part of intra-service work, some of that can be allowed to be performed by clinical staff, because these codes are evaluation and management codes, which fall under care management services, and care management services as a family are allowed to be performed under incident 2 rules, which means that the provider is allowed to have lower staff, do some of the work either through direct or indirect or general supervision. In this case, it's general supervision, which means that they don't have to be present while this work is being performed. So it's very important that this intra-service work, the part that the physician has to really focus on is really the medical decision-making in order to assess the patient's clinical stability, in addition to overseeing the management and coordination. I mean, they oversee that, but that's the part that, some of that can be offloaded to clinical staff. But it's also important to know who is clinical staff. You can't just get somebody off the street and say, oh yeah, hey buddy, you're going to be my clinical staff and do some of the triaging of this work. It's got to be a medical assistant or someone other that CMS, which I believe they have a list of who satisfies as clinical staff. So, so it's really important, because a lot of providers have that question of, okay, great, I can build these codes and have my clinical staff do all the work. Ergo, I'm going to do 1 minute of monitoring or 1 minute of oversight, and then 19 minutes can be offloaded to the staff. I would strongly caution providers not to do that, because they would not be satisfying, the medical decision-making, part of this. In my opinion, the clinical staff should do a, minimal part of the work, and, the provider is really obligated to do a majority of that. So if you want to do it in terms of the full 20 minutes, I would say, the doc has to do at least 11 minutes of that, and then the clinical staff can do the remainder. Now, add to this the complexity that the code, CMS in the most recent rule, being 2021, stated that the interactive communication, which is a requirement of the code, it's in the descriptor, must include now an audio conversation, which can be further enabled by video, but it has to be at least real-time audio interactive communication, not store and forward. And they also did specify that clinical staff can perform that part of the descriptor. So it's important to note now that clinical staff can do some of the manage or coordination of services. However, they can now also be the ones to communicate with the beneficiary with that audio conversation as part of the 20 minutes.
Say that one more time, Jaron. So basically there's a requirement to have some kind of communication with the patient about the RPM data. Is that what you're saying?
Yeah, over video.
By video.
It can be both, but really what CMS, said, at a minimum, it has to be an audio conversation. It can be enabled by video, but it has to be an audio conversation.
Yeah, and for this reason, honestly, I think that a lot of folks are looking at this and saying that, a level 2 video visit, which during the public health emergency is billed out, at $90 or something, is actually, it's half the time and twice the level of reimbursement for this type of service. And so you can actually use these data to still understand what's happening with your patients. But you can actually, if you have to already be on the phone or or on video with your patients anyway, you can actually just bill for a higher billing code than 99457 often. And so that's a conversation I've had with a number of our clients.
So you just add this on then. So
you can't do both.
Oh, you can't.
No, well, you can, but you can't do both at the same time, right? Is that right, Jaron?
Yeah, I think. Sorry, I think I was on mute. Was I on mute? Yeah, so built into any code within CPT, which is really a plug for CPT. If anyone out there is dealing with codes, needing to understand codes, really using the codes as a premise for their business, they really need to, invest in the code book and invest in the other products that CPT puts out there to really better understand the descriptors and better understand, exactly what these codes are and where they lie, because it doesn't only end with the code number and the descriptor, but there's prefatory language, meaning language before the code that explains, kind of in a guidelines mechanism, specific things about these codes. And then in parenthetical language, which it follows the codes in parentheses, which often tells you what, which codes can or cannot be used in conjunction with whatever code is in question. So the remote physiologic monitoring codes, cannot be reported in the same month with, for example, the self-measured blood pressure, codes. Now, that doesn't mean that other care management service codes can't be reported in conjunction with, the remote monitoring codes. And this is where it gets very complicated, right? Because CPT had said originally that CPT code 99091 and 99457, 99091 being for the collection and interpretation of physiologic data, and 99457 being the remote physiologic monitoring codes. According to CPT, they cannot be used in conjunction with each other. They were very explicit about this. I believe it's in the prefatory and in the parenthetical language. Yet CMS came out and said, we don't view it that way. We think that in certain instances and when reasonable and necessary, they can be used in conjunction with each other. So that adds, complexity. Because, one says one thing and the other says the other. I would follow what CMS is saying because CMS is the payer. So that's something to keep in mind. But
so that was actually a question we got about if there are services that cannot be billed during the same month as RPM. So could you go through that again?
Yeah, this is this isn't something that I can just stick in a soundbite and say, oh, you can't use it with this or that. This is a very intense thing because there are lots of codes that you cannot count anytime related to, a reported service for things like implantable cardiovascular physiologic monitoring systems, anticoagulation management, critical care. Now there are other codes that are evaluation and management codes that are office or other outpatient services that you can't count any time on the same day when the physician or the qualified healthcare professional is reporting these codes, and that would be, a litany of different types of office or other outpatient visitation services that are all E&M. In addition to that, there are domiciliary rest home services where you can't count time on the same day, along with these codes. On top of that, there are home services and home service codes where you can't count time on the same day. You see where I'm going with this, Jen. It's very complex. This is not something that can just be thrown out there and said, oh yeah, you can use it with this or that. What I will say,
how would somebody get their questions answered if they wanted to know?
Seek legal and professional advice. That's the best thing that I can add. I mean, I hate saying that because obviously it's self-serving, but the reality is that unless you're well-versed in this area, it's very easy to, make assumptions that will get you and your customers into big trouble. And, that's not what, you've got a fiduciary responsibility to your company to, make sure that you don't do that. So, and another way is obviously contacting CMS. CMS is actually, approachable. They're human beings. They're not machines. And they're there to help the public, and vendors and industry are the public as well. So, feel free to contact CMS.
Yeah, I'll say, I think that, it's really easy to get like really far in the weeds on these remote monitoring codes as we're seeing. And, I'll just say in general, I am very happy that we have movement in this space because it's certainly sparked a lot of conversations and some financial motivation around remote monitoring and how we can better care for people who are living with chronic diseases. The big challenge that I have, and maybe just shifting the conversation a little bit, we don't have to, but the big challenge I have is that fundamentally we're trying to fit what is a preventive care strategy, which is remote monitoring, trying to keep people healthy, trying to take right actions based on their data and keep them healthy and out of the hospital. We're trying to fit that into a fee-for-service
treatment
system. Yeah. Right, exactly. A fee-for-service billing schedule. And I think that's where a lot of the challenges and the rub comes from, because, you know, when I talk with physicians and health plans who are really looking at implementing this, as well as patients who have been in these programs, what they're excited about is, hey, look, we can know what's happening with a person. We can know if there's a problem early, rather than waiting until it gets to be something where they're in the emergency room because they've now developed a very bad, you know, comorbidity or something, and it's reversible. We can actually know ahead of time what's going on. And so the organizations that we're seeing that are really having a lot of traction are the ones who are more in some sort of a value-based care arrangement, whether it's, you know, an IDN, or whether it's a payer-owned provider group, or whether it's, you know, an MCO, or, you know, some sort of organization where there's just a built-in incentive to just keep the population healthy. And that's where we're seeing a lot of traction on our side, because the nuances here, the codes are just very deep.
Yeah, that's actually a great insight there, Drew, because it does, when you think about it, really lend itself to trying to keep somebody healthy, not really kind of doing a diagnosis for a sick person. So yeah, the codes are definitely set up in the
well, and
right framework.
Even, you know, Jaren, one of the questions that came out in the registrants, and Jaren, I'll throw this to you maybe to explain the details, but even I about, I don't know, a year and a half ago was asking Jaren if federally qualified health centers were eligible to bill RPM codes, and they're not. And Jaren, maybe you can explain why they're not, but it felt like to me FQHCs would be a fantastic, you know, model where you have, you know, a community-based organization is trying to serve a large number of people who many of them have chronic disease such as diabetes or hypertension, et cetera. And yet they're not eligible to actually bill for these codes. And maybe, I don't know, Jaren, if you can explain why that is, but.
Yeah, so FQHCs are paid according to something called AIR. It's an all-inclusive rate, you know, which basically gives the FQHC an allotment of money, and they have to spend their monies within that allotment, given the, you know, provision of specific services that are allowed, you know, by CMS. And CMS, I believe, seems to feel that things like telehealth do fall under this all-inclusive rate, although, you know, that's suspect to me and questionable as to whether or not that really is in practice something that is even feasible. You know, an argument that we made, you know, we being the stakeholder community, because I'm aware that other people made the same argument, was that when last year CMS was considering, you know, the creation of a code which would cover a number of chronic care or care management services. And by this, they were saying, look, we're going to offer the ability to be able to have just one code that covers some care management services. Some of us made the argument that that code should actually include remote monitoring as well, because that is a care management service. Why wouldn't they do that? And, you know, there are obviously many FQHCs that are very interested in being able to provide these services. The response back was unfortunately, you know, no go. I know that, again, this year's fee schedule has a question on FQHCs, again, relative to those care management services that they are allowing. You know, I think it behooves all of us to make the same argument, you know, hey, it's great that you're adding services to FQHCs under this blended code. It would be wonderful if you guys would consider adding remote physiologic monitoring, which happens to be, you know, a care management service. And on the FQHC, you know, side of things, I would actually, you know, throw a plug to, you know, an industry contact who does a lot of work in that area. Sylvia Trujillo is really a leader in this area. She's formerly with AMA and now with OCHIN. that would be a good area for EHI to work with as well.
Do you have a sense, Drew, maybe you can answer this actually. Are you seeing these RPM codes primarily with commercial providers, Medicaid, Medicare? Where are you seeing this?
Yeah, it's actually all of the above, but candidly, most of our clients are focused on CMS, but what we're seeing is that most of the commercial payers are following suit. The biggest challenges that I'm seeing is that the reimbursement levels are not always the same. Oftentimes the reimbursement levels are, from what I'm hearing, are higher on the commercial side than from CMS. But yeah, we are seeing the health plans follow suit, and especially programs like Medicare Advantage, et cetera. We're seeing those follow suit very directly because they're taking on the same populations.
And Jaron, I guess along the lines of fraud and abuse, people are wondering, what do we have to do to really be able to prove that we've looked at the data or had an audio conversation with the patients? I mean, what's actually required there? And is that something that I'm assuming there's a lot of fraud and abuse on?
Well, I think these are two separate items, and I'm glad that you mentioned fraud and abuse because one thing is your the requirements of your codes and billing requirements. I'm not a coder or or a biller, so I would not be able to give that kind of advice. I would say that whatever you typically provide to satisfy the requirements of billing any code, these codes are no different. You follow the same formats. In my opinion, more insights as to when the conversation was held, what was discussed, that kind of stuff should be included in your notes section. But again, seek advice from a biller or a coder who actually is involved in billing these codes. But separately, this issue of fraud and abuse, constantly comes up, particularly in the telehealth space. And I think it was very telling that earlier this year, OIG issued a statement on, concerns that have been raised over and over again on enforcement actions related to, telefraud, which is a scheme that really is a combination of bad doctors conducting sham remote visits, as opposed to, not conducting sham visits, but rather perpetrators that are billing for durable medical equipment or genetic testing, having, lied to beneficiaries who are unsuspecting, which is very different than telehealth fraud, which there's practically no as far as I know no examples out there. There's some minimal, but not many, and that's a big deal because when these policies, especially the public health emergency policies, and making them permanent are raised, everyone on the Hill recently, the chatter I hear is, we can't really do that because there's a lot of, fraud and abuse in telehealth. In particular, they always kind of equate that then with, this issue of, people who, are being,
right.
You see what I'm trying to say. But anyway,
yeah.
So I think it's a problem. I think that's a real big problem because telefraud is very different than telehealth, and telehealth is minimal, from what I understand.
Well, that's an argument for value-based care right there. Hey, Jaron, I'm wondering if you could just weigh in. I mean, you mentioned during the public health emergency, maybe you could just touch on really quick. Like, I know that right now copays are, I'm going to say this in a way that's not accurate, but you can clarify this. But copays are waived or not being billed right now as part of RPM and a host of other services.
Yeah, they're under the discretion of the provider. So the provider typically has to charge the 20% copay as part of the Medicare contract with a beneficiary. Beneficiary, has to pay 20% of the service as a copay. That makes sure that their skin is in the game and that they're aware that they're paying for this, and they have to have consent and all those things. Right now, the copay side of that has been, in essence, they've given the provider the discretion to not charge the copay if they're not interested in doing so during the public health emergency. I know that has been a very, important thing, development, because lots of those providers who are involved in remote monitoring don't want to charge the copay because it's typically a non-starter. You know, it's a barrier to these virtual services because, you know, if you're on a limited budget, even if it's $10, $20, $30 a month, it means something. And, you know, people would rather forego that than have to pay it. Now, you know, once the public health emergency is either lifted or isn't reauthorized or expires, you know, it goes back to normal, along with many of the waivers that are instituted currently. You know, they go back to what we had beforehand. And it's going to be a problem. And, you know, I know that we only have a few minutes left, but at some point I did want to talk about utilization, because I saw a couple of questions on utilization. You know, basically in 2019, the remote monitoring family, which I'm going to include 99091 under that family, so 99091, 453, 454, 457, 458. The dollar amount that was reimbursed, according to calculations that were done by a colleague of mine, she's a student at George Washington Medical, who I've worked with, Millicent Corte. So shout out to Millicent for crunching these numbers for me. Amounted to around $7.9 million. In 2020, the number that she was able to crunch, given the publicly available data that I shared with her, is around $50.2 million. That's a 635% increase, you know, for RPM. And I'm not aware that anybody out there has published any numbers. You know, again, I'm qualifying these as is publicly available data. We did the best that we could. Millicent does great job in this area. You know, but, you know, they're as perfect as we are, which means that we're imperfect. So, you know, use them for what that's for.
Jaron, what pathologies or what types of devices were used the most?
No, we don't get to that level of granularity. We only crunch the overall total number of undiscounted services, which in 2020 seems to have been right over 1 million. In 2019, it was just over 177,000. So that should give you a good idea of how much RPM grew by, you know, year over year. And the 2020 figures don't include the whole year. They only include up until the fee schedule was released, you know, and really probably a month even before that. So it'll be interesting to see the final figures when they get released, either at the end of this year or next year, and then see total what the expenditure was in 2020 for RPM services. But really, really big jump. And we expected that, right? I mean, it's a public health emergency.
Interesting. Are we seeing a lot of uptake by clinicians in terms of adopting this technology, or is the reimbursement issue just too confusing? I mean, what's been the change over the last couple of years? I know Drew or Jaron, if either of you have information on that.
It's a great question for Drew.
Yeah, I'll say clinicians are adopting these technologies really at unprecedented rates. I mean, especially, you know, this is the one thing that I think COVID really did kind of help shift in this area, which is, you know, 18 months ago, clinicians often wanted these data, but it was oftentimes sort of a challenge of priorities inside of these large healthcare organizations around, well, how do we actually, you know, set aside the funds to actually enable these programs? And today it's the opposite. This is the top of everybody's mind. This is where everybody's going. Everyone's putting budget forward toward this. So there is a lot of adoption. And, you know, where we're seeing a lot of the adoption is from folks who are looking at their remote monitoring codes as, once those get sort of hammered out and streamlined, this is, you know, there's potentially a there. So that could be nice for the fee for service business. But many folks are just implementing remote monitoring and technologies anyway, because what they found was that when we all went virtual a year ago with the pandemic, or a year and a half ago now with the pandemic, you know, video visits were fine, but doctors need data to care for their patients. And when you have a patient living with chronic disease and you're used to seeing them in the office every quarter and getting the A1C check or getting the blood pressure check, et cetera, you don't have access to those data when it's all virtual. And so they're now looking at how do we actually implement these programs where we can get these virtual data. And again, the value-based care arrangements are really where we're seeing a lot of the traction today.
Well, this has been an incredible speed session. And I really want to thank Drew and Jaron today. We have a lot more questions. So let me just ask this, Jaron and Drew, where would you direct people for more information? I know I heard CMS, and CMS, I'm assuming, has the FAQ section on this.
Yeah, absolutely. I mean, so we have some great blogs at Validic.com on our blog where we've gone through this, and Darren has provided his input on some of those. And then I would also just encourage you to look at other groups out there. Nixon Law has a nice blog post on this topic and subject, and so I would just encourage you to really start looking at those. And then if you're ever interested in how this technology can actually be brought into the clinical workflow, please reach out to me and Validic. We'd be happy to help explain sort of the tactical part of how this really works at scale.
Jaron, anything you want to add?
Yeah, from my perspective, I would steer people to AMA. AMA does have a number of instruments on their website that are there publicly available for free that give insights on these codes. I would look at CMS information and any kind of publicly available stuff. I'd also look at firms in particular. Nixon's one, Foley Hoag. Nate Lackman does a great job. He's got a 3-part series that he issued on the newest codes, which I would strongly recommend. In addition to that, look at medical specialty societies. I would actually, present party, very much accepted since I work with them and Validic does what they should do. I would stay away from vendor websites. There's a lot of garbage out there that will steer you the wrong way. So I would not go to, to other corporate websites. But I would go to medical specialty societies, which have a litany of informative documents on their websites as well, which are typically well done. So that's what I would do.
That's a great suggestion. We'll actually send out some of those links that you guys just mentioned now in our follow-up note with a link to the recording today. I do want to thank both of you for joining us for this power session. This has been incredible. We got through so many of the questions that people sent in advance, as well as those that were posted. So thank you, everybody, for joining today. And we will hopefully do this again soon. Thanks, everybody.
Thank you.
Thanks, Jen.